Right. Hello and welcome to today's episode of the Friday Chalk Talk. Today I'm happy to introduce Dr. Lisa Peterson, who after experience in nephrology and critical care has led herself here to a critical care fellowship with us at St. Luke's. Today, Dr. Peterson is going to be talking about medical assistance in dying. So I will pass it over to you.
Hi. So honestly, I did this topic because I really didn't know this was a thing. And then I started reading about it, and there seemed to be this conflict about most of the literature was on ethics. And I wanted to know more about the science, like how did they figure out how to do this medically? So that's really where this came from. Can we go to the next slide? So the objectives is really just talk about how this came to be and goals and why they changed the medicines and what medicines used to be used and what's used now. And the process of this differs depending on where you are in the world, and then what makes people want to have this procedure. And then I have no financial conflicts of interest to disclose. Next slide. So where is this legal? There's 11 states that this is legal in, and plus Washington, D.C. And you can kind of look at the various places, and they differentiate this by euthanasia versus self-administered medications. Euthanasia is given by a medical professional, and Canada allows this to not be a physician. And then there's also the self-administered method where the physician writes a prescription, but the patient takes the medications themselves. And some places allow for both of these methods. Very many places only allow for one of them. And then Canada allows generally for both unless you're in Quebec. So this is not consistent across even the same country. And there's more countries that are on the docket. Portugal's actually passed the legislation 3 times, and it's been vetoed 3 times by their president. There's a bill in front of the House of Lords in Britain currently, but they don't think this is going to pass. And then in France, this is going to be debated in the legislature this year in 2023. Next slide. So I'll let you kind of look at the timeline, but this really started, Switzerland said that suicide was not illegal, and they, in their public health reporting, don't differentiate whether this is assisted or not assisted. And then the Netherlands follows in 1973, and they didn't make it legal, but they didn't make it illegal. And then I'm going to talk a little bit about Dr. Kevorkian. Just because of my age, I kind of remember this from teen years, kid. So he says he helped 130 terminally ill people end their lives. This is between 1990 and 1998. His license was revoked in 1980 or 1991. So a lot of these happened after his medical license was revoked. In each of these cases, per Dr. Kevorkian, the patient made the final motion or action that caused their own death. He actually invented machines that would allow this to take place. One of his machines he named the Mercy machine, and that was an installation of carbon monoxide into an enclosed space. And then the other one was an IV pump that the patient would just hit the button and infuse their own medications. And he named that one the Thanatron, and that's from the Greek thanatos, for death. So he ended up getting convicted of second-degree murder. He served 8 of a 10 to 25 year sentence. And that was, he was convicted for the second-degree murder of a patient named Thomas Yauk, Y-O-U-K, and he had end-stage ALS. Next slide. So again, you can kind of read the timelines. The KNMG and the KNMP from the last slide, this is the Dutch Medical Professional Society and the Dutch Pharmaceutical Professional Societies. And in 2007, they wanted to publish guidelines so that people would be doing this consistently in a way that they thought was effective and preventing any adverse effects. And so they came up with guidelines in 2007, and these included coma induction. Their previous method had been to use thiopental, and they added propofol to induce coma. And then this was followed by neuromuscular blockade agents. And in 2010 to 2012, they reconvened and they rethought these guidelines. And they wanted barbiturates for oral method of medical assistance. And then they still used propofol or barbiturates, followed by neuromuscular blockade for euthanasia for the IV physician administered method. They did add an appendix that I thought was pretty interesting. They had a list of medications they recommended not using, and these included benzodiazepines, opiates, insulin, and potassium. So they published these guidelines in 2012, and the other change they made at that time was previously they had recommended in 2007 to use 9 grams of barbiturates, and they bumped that up to 15 grams. And the reason was that the rate of death took a lot less time, and they had gone from up to 2 hours down to about 30 minutes with that 15-gram dose. Next slide. So in the States, this became the face for the Oregon law. And Brittany was a 29-year-old female when she was diagnosed with astrocytoma. And she was diagnosed in January of 2014 and moved from California. She was raised in California. She went to UC Berkeley. She had a master's degree in education and traveled. She taught in Nepal and Vietnam. So she went home to California. She gets diagnosed and she knows that she does not want to suffer. So she moves to Oregon, because Oregon at the time, you had to live there for 6 months to avail yourself to these services. So she moved to Oregon. And in that interim, she made a video saying what she did and why she did it. And her family took the video back to the California legislature, and they it was really instrumental in getting the law passed. The law in California was called the End of Life Option Act, Senate Bill 128. And so they think that the video from Brittany was instrumental in getting that ratified in California. And then that went into effect in 2016. Next slide. So we kind of go back to, you can kind of see when everybody's passing their laws, that this is okay or not okay. And the big one on this slide is in 2015, pentobarbital is no longer available in the US. So now you have to go to secobarbital. And when pentobarbital was no longer available, the price of secobarbital went from $300 for a lethal dose to $3,500 for a lethal dose. So now this becomes pretty inaccessible for people who want it, because now they can't afford it. So there was a group of physicians that were doing this in Washington State. And in 2016, they called themselves the End of Life Gathering. And they designed a new protocol to help patients. And they called this DMP, and that stands for diazepam, morphine, and propranolol. And they used this for a while. They ended up coming up with a new protocol, DDMP, and they added digoxin to this, and then they changed the doses, and that's what became DDMP2. And by 2017, that was the most utilized protocol regimen in Colorado. Whereas in Washington and Oregon, people were still getting the secobarbital. And in 2017, DDMP2 was a gram of diazepam, 50 micrograms or 50 milligrams of digoxin, 15 grams of morphine, and 2 grams of propranolol. Very bitter. It's hard to get down. And that's at some point, we'll kind of talk about how that changed. And that cost about $650. Next slide. So in 2018, Canada decides that they need to report on the science of this, and they want this to be the same across Canada. They're calling it their pan-Canadian approach, and they want this to be practiced the same across all of the various provinces. They published their own protocols in April of 28. And in 2018, of all deaths in Canada, a little over 1% in the first 10 months were attributed to medical assistance. And you can kind of see how the rest of the world, again, it's just being made legal in more and more places. Germany, it's not legal, but they did the same thing that Switzerland did back in 1942. It's not legal, but it's not illegal anymore. 2019 now, secobarbital is very difficult to get a hold of. And then the other big thing for this slide, and it just happened, I'm sure we'll hear more about it this year, is that they added mental illness to the list of terminal illnesses that would qualify you to have medical assistance in dying. Next slide. So these are the professional society positions. These are published, easy to find. And everybody has this very studied, stable, neutral, it's okay if you do it. We don't necessarily want to say we agree with it. We don't think it's bad. But also I think the thing that's consistent among all the palliative care societies is all of the societies want to make sure that people are not seeking out medical assistance in death because they're having uncontrolled symptoms like pain or nausea. And they all make it pretty clear if you read further on into not just the published statements, that's really the main concern and the place that they are all coming from. They also do, everybody kind of makes a comment that you're just never going to get consensus on this point. But I think the one thing they did all get consensus on is they all wanted people to make sure people had good fundamental palliative care prior to making any decisions. So what do people think about this? Next slide. This is a Gallup poll over 3 years. And so when a person has a disease that cannot be cured, doctors should be allowed by law to end the patient's life by some painless means if the patient and his or her family request it. And you can see over time, stable to a little bit more people agreeing with this. Next slide. They broke this down by race. So white people agreed 77%, non-white people 65%. Age groups, younger people were agreeing with this statement at a higher rate than people 55 plus. Men, 75%, women, 73% agreed with this. And then next slide. They broke this down by your political affiliation and your political ideology. So if you were a Democrat or Republican, and then if you thought of yourself as liberal or conservative. So again, really over half of people, well over half of people, no matter how they identified themselves, were in agreement with that same statement. Next slide. So this Gallup poll, this was a little bit of a different statement. The other one was all the exact same question. When a person facing a terminal illness it is morally acceptable to ask for a physician's aid in taking his or her own life. And then they broke this down by religion. And you see the numbers there. They also broke this down by education. College graduates, 79% agreed with that statement. High school or less, 71%. And then Marty and I were looking at this, and the views of other, I don't know, seemed a little unrepresented. Can we go to the next slide? So I did sort of dig into that a little bit, and there's definitely published studies on what people think of this. And they did interviews with various groups of people. They did groups, they had the Muslim RNs, a very negative attitude. Indian Muslims also very opposed. That elderly Muslim women who did not live in their own country or where they came from. They were immigrant women in Belgium, negative. And this is where they start to talk about intrinsic religiosity. So the more religious the people were, the more they opposed medical assistance in dying. And if you look at the bottom statement, that is also very true among Jewish people. The Orthodox and Hasidic people were much less likely to be accepting of euthanasia, whereas the more secular you get in that religion, the more likely they were to be accepting of euthanasia. Chinese Buddhists, over half of them, these were elderly Chinese Buddhists, agreed that this should be allowed. And then elderly Jewish women in Belgium disagreed. Next slide. This one I found funny because it's the Central Conference on American Rabbis, but they were talking about the Canadian law. So their view is there is, pardon my pronunciation, Rafuat Haguf, sorry, is the health or the curing of the body. And when they say that is no longer accessible, then Refuat Hainfesh is healing of the mind, body, or the mind, spirit. They say that if you can't heal your body, then it's not unreasonable. If you think death will heal your mind, that it's not unreasonable to avail yourself to these services. And again, this is American rabbis commenting on a procedure available, and this is from New York, was where they met, available in Canada. And you can just kind of read what they thought, but they did not think it was unreasonable that a Jewish person would avail themselves to these services. Next slide. So some of the issues, and these mostly come out of Canada, is where the publications are coming out of. They talk about the communication between the healthcare providers. So if your psychologist is not talking to your primary care, it leads to a lot of problems. Inconsistently applying the eligibility to different groups of people. And one of the examples that they give is if you are in Ontario, it's hands off. It's everybody's, you have to coordinate your own care. You have to get your psychologist to talk to your primary care. There's very little that's going to help you navigate the system. Whereas if you're in Alberta or Manitoba, it's very centralized. This is all put into a chart and everybody talks. So it makes it easier or harder to navigate the healthcare system depending on where you are, even within the same country. Federal legislation, even the laws are not the same across the provinces. In oral medical assistance is illegal in Ontario, I want to say. And then it's only euthanasia, but then euthanasia or oral is available across the rest of the country. Next slide. So this is the progression of the medicines. So it started with the barbiturates, and then there was no more pentobarbital as of 2015. And then your segabarbital, your price goes from $300 to $3,500 for one lethal dose. And then the next recommendations was the pentobarbital with chloral hydrate and morphine. And the chloral hydrate, they found out, was just burning everybody's throat. So they changed the protocol, the recommendations. And that's when you get into the DMP. And when they looked at the DMP, the first iteration of this actually went pretty well. The first two iterations, their goals were to put a patient to sleep, to keep them asleep with no pain, and they wanted death quickly. And at that time, they defined death quickly within an hour or two. So they used this DMP protocol, and the first two deaths go fine. The third death, the guy took over 18 hours to die. And that was what prompted the DDMP and the DDMP2 with the changed doses. And then that was when they added the digoxin. Seconal still acts faster and is the drug of choice if money is not an issue for oral. The DDMP2 you can still take hours to die, and it's just really, really bitter. And then they recommended the bottom line is all the antiemetics that they've recommended. And there have been no head-to-head trials. There's no one that's recommended any more than any of the other ones. They just sort of say you're probably going to need an antiemetic because this stuff tastes so bad. Seconal, 94% of patients die within 30 minutes, and DDMP, 94% of patients takes about 2 hours. DDMP actually does not work as well if you have pre-existing high doses of opiates that you are on, which is going to be quite a few of these patients. And so they said to know that it may take longer for those patients to die. Next slide. And then this is some of the data where from the Netherlands and why they changed some of these doses. You can see in time to death in less than 30 minutes went from 70 to 82% when they changed that dosing from 9 or 10 grams up to 15 grams. And the timing of that change was just after 2011 was when they started recommending the higher doses. Next slide. Oh, I just want to say one thing about the Netherlands. You don't have to go back on the slide, but in 2019, they had 6,361 assisted deaths. 4 of those, they did not use the protocol. That's 0.06%. And what they did was they did case reviews of these 4 patients and published them, like highly published them in the Netherlands, because they really want people to follow the protocol and they want it to be transparent and what any issues might come up and how to deal with them. So they make any deviation from the protocol very, very public so that those things don't happen again. So why are people asking for help with this? This was from British Columbia, and they looked at 250 people and ultimately 112. They looked at the further numbers of why they asked, and mostly it was pain and nausea. That was 73-ish%. So this is why the palliative care associations are saying, you know, if we're taking good care of people, this should be less of an issue. And then loss of autonomy, independence. You can sort of see the other issues that people were complaining of. So in 2016, about 1% of deaths in Canada were due to medical assistance. In 2021, there were 10,000 people, just over 10,000 people, and it was now 3.4% of deaths. So it's definitely gaining traction, at least in Canada. Next slide. So in Oregon, they published their experience, and you can read, but it's older white people with cancer who were enrolled in hospice, who were did not want to lose autonomy, and most of them were able to die at home. And the other big reason was just not enjoying things that made their life enjoyable anymore. They couldn't do those things anymore. Next slide. Tom, I'm reading your thing, and yeah, I had the same thought, like, who thinks of this? And then I'm like, well, I'm thinking about it. So this was another really interesting thing that I'm just fascinated at what people look at. So they looked at the relationship of the palliative care teams and the people that were providing medical assistance in places where it's legal. So in Belgium, these are like siblings. These two grew up together, and they all work very well together, and they talk to each other. A lot of them are the same physicians, but not necessarily the same physicians. Either way, they work together really quite well. And the people that, if they wanted MAID and their palliative care physician didn't do it, then they were at least willing to talk to the physician who was going to do it. They talk about conscientious objection, and they talk about conscientious participation. So this is sort of the place where those two groups work the best together. Next slide. So Switzerland, it's a third, a third, a third. You have a third of palliative care physicians who want nothing to do with this. You have a third of palliative care physicians who are willing to consider it or refer their patients to a service, and then a third of palliative care physicians who will be involved and will help. In Switzerland, it's a little odd because this is generally done by lay people, which is also why you find in Switzerland, they'll find ways to do it that don't necessarily involve a prescription. And there's Dignitas, there's quite a few pretty famous large groups in Switzerland that help with this service. But it's definitely a little different. Next slide. So Oregon and Washington, it's just really all over the road. They talk about hospices. About half will have participation with physicians that will provide this service, and then 25% no official participation, but maybe some. When they looked at the social workers and the hospice RNs, the vast majority of them said that their hospice should be neutral or supportive. So the people in the hospice working there wanted at least to not be, in opposition. They talked to chaplains and social workers. In Oregon, 50-50. In Washington, 78% of the hospice programs had a policy that prohibited staff from being present at the time of ingestion or between ingestion and death. And then again, you have this just all over the road as to whether they're opposed or not interfering, not participating, or supportive. Next slide. And then Toronto. So Canada is the only place where non-physicians can administer the medications. So your nurse practitioner that's really where the word medical assistance in death came from. And that's when it changed from physician-assisted death or physician-assisted suicide to medical assistance in death. That nomenclature came out of Canada for this reason. And again, the palliative care and the medical assistance in dying groups work really pretty well together. This was just a quick study where they sent out a questionnaire to physicians from multiple specialties in Sweden. And they just noted that the response rate had gone from around 35% in 2007 up to almost 50% in 2020. And a third of those physicians polled would be willing to prescribe the medications. And then they also talked about the trust in the healthcare system. If whether or not if this became legal, or if this was discussed, would you trust your healthcare system more or less? And a lot of more people were saying it wouldn't be influenced, whereas that number was lower back in 2007. Okay, on to Switzerland. Next slide. This is the sarcopod, and this is short for sarcophagus. It's an airtight capsule, and they can keep the CO2 levels very low. They can lower the oxygen level in less than a minute down to far less than 1%. And this was inspired by a man who was in Britain who had locked-in syndrome and wanted help dying. His name was Tony Nicholson. So essentially, if you are in the pod can be made, it's made by a 3D printer, and they can make it out of whatever you put in the 3D printer. And there can be different controls put in this. And so just like you could work a computer with a gaze, you can with a gaze with your, because you're going to have preservation of vertical eye movement. Even in locked-in syndrome, you'd be able to turn this on yourself, because in Switzerland, it's illegal to turn it on. You can do everything shy of that. And so this was what was invented to help this man, Tony. But they could be different kinds of switches for people with different disabilities. Next slide. So they wanted to show how portable this was when they debuted this. So this is a picture from Venice, and they're showing you how portable it is. Like I said, it's made by a 3D printer. They can print it out of wood amalgam or something else that's biodegradable. And then this can also be used as your coffin. They can make them a little wider and they can hold 2 people. They can be made of sturdier material. You can reuse them. And then they will pull the oxygen out and replace this with either helium or nitrogen. And they say it's painless. I don't know. Next slide. This was the other thing, and kudos to somebody that looked at this. They were talking about what happens after, and is the grief the same, and is bereavement counseling, should that be the same? So they really just started looking at this and what the factors were that would complicate the grief if you lost somebody who had a medical assisted death. Can we go to the next slide? So they interviewed 9 family members, and anywhere from 4 months to 3 years after they lost someone they loved. I have a feeling this is going to be biased, because when you really look down at this study, every single one of the 9 family members was a middle-aged Caucasian female. They did find 3 themes that came out. The first one was this parade of lasts. So you have a known date, which really threw people when you read about the various bereavement, when they talk to people about bereaving somebody after this. Having that absolute time is there's just a cognitive dissonance. Like, you're not supposed to be able to predict that. Even as palliative care doctors, I was like, I can't give you an exact date. And this was challenging for a lot of people. And it was funny, the second part, so it's split among the people. The doers and the planners and the people like want a to-do list and to cross it off actually did fairly well with this. They took this as, well, I can plan and I can pre-grieve and I can digest some things. The people who weren't the planners and the doers did not do so well with trying to pre-grieve and digest and having this preset date. The one thing they did find that was having this as a ceremony and planning it kind of slowed down all people, and that was helpful for them. The one thing that families had asked for later, all of them, every single one of them, said they did not understand how quickly, once the procedure was started, that their loved one was going to die, and that they were not educated enough on what was going to actually happen in those few minutes. Next slide. And then this also, so they talked to the physicians that provide these services, and it was really about the same in all of them. 12 to 13 of the 18 physicians polled all felt that the bereavement was different. They all thought that they had a professional moral obligation to provide bereavement services. They all felt that it was important, and they all felt like they didn't have the time or resources to provide said support. All right, and that's it.
Thank you so much, Lisa. There's definitely been some chat going on in the chat box, but I'll let Marty kind of start off. He's got his hand raised.
So I've been thinking about euthanasia and physician-assisted death and MAID this past week. And the thing that came to mind to me was actually affective forecasting errors. And I don't know if everybody here has heard of that before, but where I read about this first was from a study in 2008 by Jody Halpern and Bob Arnold. And they talked about this term affective forecasting errors, which is how we all as humans kind of struggle to envision our ability to adapt to changes in our own healthcare over time. And this has practical implications to everything we do in palliative care and advanced care planning and thinking about our future limits. But I just wanted to share sort of the 3 big ones, because these are the things I think about when I think of people who might be considering something like this for themselves. So one is, it's called focalism, where we focus too much on what is going to change and what might be lost, rather than seeing all the things that are going to stay the same with our illness. The second one is immune neglect, where we may fail to appreciate how strong we are and how good our coping mechanisms are and how we can buffer with some of the changes and losses that happen with time. And the third one is that sometimes we fail to predict how well we can adapt. And I think we struggle that our values might change over time. And we are all witness to these things, right? We have a goals of care conversation with a patient or a family when they are a bit more upstream. And then as their illness changes, sometimes their values, their limits, their coping changes too. And so that it's not really a question, but it's just what's on my mind as I think about these people.
So Andrew, we have 0 policies at Aurora Advocate because it is not legal here. So I don't feel like the powers that be have felt the need to make any sort of policy because it's just illegal.
I totally forgot. I was just in Wisconsin too.
Yeah, the lawmakers have made the policy so far.
But it does bring up an interesting point that just because it's legal in that state, it's up to the individual institution and it probably also the individual provider of where they stand on it and whether or not it's offered. So just like any other treatment we give or provide, you know. Okay, and then kind of some other chatter that I thought was interesting to put out there was, how does this go for insurance payout as well as coverage? I think one thing that was brought up was that it's not considered suicide anymore. It's aid in dying, to change that nomenclature in order to address some of the insurance concerns, which is an interesting perspective that I wouldn't have thought about either.
Yeah, I did not come across insurance coverage. I mean, that's going to be a whole other chalk talk, right?
Exactly. And then I think the only other big topic that was kind of brought up was kind of to that point of what about other symptom management to help get before that point and that's really all we can do in those states that don't offer it, and those facilities that don't offer it, is how do we really make that symptom management so we can improve their quality of life?
Yeah, I mean, when you looked at it, I think the lowest was 70% of patients had palliative care. And then a lot of them were 85–90% of patients were being seen by palliative care at the time. So something's going on there. The other thing though, is if you dig deeper onto that, a lot of patients had only been seeing palliative care. So that was a yes, no question in a lot of these. Some of them looked at how long, and the problem there was they had been seeing palliative care for 3 months or so. There's definitely room to improve.
Yeah, I think so.
Yeah. Remember that early referral thing that we talked about?
Early involvement. Yep. Okay, well, I think that's pretty much everything for today. So we'll wrap it up here. Thank you so much, Dr. Peterson, for this engaging topic and for the information that I'm sure will sit with us for a while. So thank you so much.
Well, and if people want the slide deck, there's a couple other slide decks. Like there's tables of what's required in all the different countries where it's legal. So if somebody wants the slide deck, just feel free to shoot me an email.
All right. Thank you so much. Happy Friday.
Thanks.